The following educational video was developed to help the viewer identify and interpret clinically significant telemetry events that occur while patients are being monitored on inpatient telemetry. By the end of this video, the viewer should be able to define the current guidelines for appropriate and inappropriate use of inpatient telemetry monitoring and to understand some logistics related to ordering and placement of patients on telemetry monitors. The main focus will be to help the viewer develop a step-by-step method for comprehensively evaluating telemetry to identify clinically significant events. Furthermore, the viewer will also develop a step-by-step method for determining the etiology of an arrhythmia when one is identified. Finally, the viewer will review patterns of common arrhythmias and learn to distinguish a true arrhythmia from telemetry artifact. We will begin by reviewing the current American College of Cardiology and American Heart Association appropriate indications for the use of inpatient telemetry monitoring. The following are Class 1 indications. A Class 1 indication means that the benefits outweigh the risks, and these patients should be placed on telemetry monitoring. Class 1 indications include patients in the early phase of acute coronary syndromes, following implantation of an ICD or a pacemaker if the patient is pacemaker dependent, high-grade AV block including Mobitz 2, 2-to-1 AV block, and complete heart block, long QT syndrome and associated ventricular arrhythmias, acute heart failure, loading of an antiarrhythmic medication which is known to cause long QT, and following cardiac surgery. The following are Class 2 indications. A Class 2 indication means that the benefit is likely to outweigh the risk and that it is reasonable to place these patients on inpatient telemetry monitoring. This includes patients more than 48 hours following an acute MI, patients presenting with chest pain syndromes who are being ruled out for ACS, adjustment of rate control medications in patients with chronic atrial fibrillation, patients presenting with subacute heart failure, and patients presenting for evaluation of syncope. The following are Class 3 indications for inpatient telemetry, meaning that there is no proven benefit, and these patients should not be placed on telemetry monitoring. This includes patients following low-risk surgery, patients undergoing labor and delivery without significant medical comorbidity, patients with chronic stable atrial fibrillation, and patients with asymptomatic PVCs or non-sustained ventricular tachycardia when they are hospitalized for other reasons. In this next section, we will review what happens when a telemetry order is placed. When an order for inpatient telemetry is placed by the physician, the following monitor is used. Notice that there are only 5 leads that are placed on the patient and that these leads represent modified limb leads. Except for V1, no other precordial leads are used. Once the patient is connected to the leads, the telemetry is displayed in real time on one of these telemetry monitors located on each inpatient floor. The telemetry will automatically alarm on the floor if certain arrhythmias are detected, such as ventricular tachycardia or ventricular fibrillation, or bradyarrhythmias such as pauses or significant bradycardia. The monitor may also alarm and start logging clinical events based on heart rate parameters, either high or low, which are set by the nurse depending on the patient's particular clinical situation. In addition to the automatic alarms that sound on the floor, all patients not in an ICU are also monitored in a central telemetry area located on Feinberg 15. Central telemetry will call the nursing station of any patient when a significant arrhythmia is identified. It is important to note that events can be viewed and printed in central telemetry even several days after they have occurred, which is not always possible on the floor monitors. Furthermore, central telemetry can even pull up rhythm strips for a short period after the patient has been discharged. In this next section, the viewer will develop a step-by-step method for comprehensively reviewing inpatient telemetry. This process should be performed at least once a day for every patient being monitored on telemetry and should also be repeated as necessary if the patient experiences a clinical event such as syncope or describes palpitations. The first step is to identify the patient on any inpatient telemetry monitor. Telemetry monitors located on almost every inpatient unit will display real-time telemetry for the patients located in that unit. Clicking on a specific patient will enlarge that patient's real-time heart rhythm. For ICU patients, in addition to the heart rhythm, oxygen plethysmography and waveforms of indwelling lines, such as an arterial or central venous catheter, will also be viewable. By clicking on View Other, a drop-down menu will appear through which a provider can pull up the real-time telemetry of patients located anywhere in the hospital. Therefore, one does not need to be on a particular patient's floor to view their telemetry. The next step is to click on the Graphical Trends button and to set a heart rate range and time interval. This will allow one to view global trends in heart rate over 24 hours, as well as to then focus more closely when abrupt changes in heart rate are noted, as this may signal the occurrence of an arrhythmia. Clicking on Graphical Trends will reveal changes in heart rate over the set time period. The heart rate can be changed to different ranges that may make clinical sense based on the patient's baseline heart rate. Additionally, the time range can be changed to reveal the heart rate trend over as little as 15 minutes or as long as 24 hours. It is generally best to start with a 24-hour view of the heart rate to assess the heart rate trends over an entire day. This is particularly important in patients in whom medications that affect the heart rate are being titrated to achieve a desired response. Furthermore, in the 24-hour mode, one can easily see abrupt changes in heart rate that may indicate that an arrhythmia has taken place and should prompt further evaluation. Here are some examples of normal and abnormal graphical heart rate trends. In normal sinus rhythm, the graphical trend line is very thin and reveals gradual increases and decreases that are physiologic and occur throughout the day. Notice there are no abrupt spikes or decreases in heart rate. In patients with pacemakers who are pacemaker dependent, the graphical trend line reveals a flat trend line with little or no variation. This is because the heart rate is dependent on the lower rate limit of the pacemaker, usually set to 50 or 60 beats per minute, and will not go below this as long as the pacemaker is functioning properly. In patients with atrial fibrillation, the normally thin trend line seen in sinus rhythm becomes markedly thickened. This is because with atrial fibrillation, there is beat-to-beat variation in the duration of the RR interval. Thus, the calculated heart rate varies considerably from one beat to the next, causing the trend line to be thick. In this patient with paroxysmal atrial fibrillation, notice the difference between the thin trend line during sinus rhythm and the thickened baseline during the 2 episodes of atrial fibrillation. Notice also that each episode begins with an abrupt increase in heart rate. This next example is from a patient with paroxysmal supraventricular tachycardia. Notice that there are frequent abrupt increases in heart rate that occur instantaneously, which suggests a possible arrhythmia. Furthermore, notice that in each instance of the heart rate change, the heart rate increases to the exact same rate and then plateaus. This is very consistent with supraventricular tachycardia. Depending on the rate of the supraventricular tachycardia, as well as looking at both the initiation and offset closely, the exact etiology of the supraventricular tachycardia can often be diagnosed. As mentioned, when an abrupt change in heart rate is noted in the graphical trends, this event must be more closely inspected as an arrhythmia may have taken place. One can move the cursor over that area and then change the heart rate interval to 15 minutes to better determine the precise time of the initiation of the change in heart rate, as well as the time of the termination. Using the graphical trend approach to identify the time of abrupt change in heart rate is the first of 2 methods for identifying possible arrhythmias. We will return to this later in the video when we focus on identifying the onset and termination of arrhythmias. In addition to viewing graphical trends and identifying periods of abrupt change in heart rate, viewing alarms that the telemetry monitor has automatically stored is the second method of identifying arrhythmias. In general, one should view all alarms daily and closely inspect alarms for the presence of a true arrhythmia or determine that the alarm was actually artifact. To view the clinical events, one clicks on Events and sorts by type of event or time. By clicking on the type of event and then clicking on the drop-down, different categories of arrhythmias are displayed and can be viewed separately. Categories include tachycardias, such as ventricular tachycardia or ventricular fibrillation, bradycardias, including pauses or asystole, and ventricular bigeminy. Each event can be viewed one at a time by clicking on the event and then either clicking on Event Strip or FD Strip. One can also view events by switching from event type to time. Time displays a chronological log of all logged events, which can then be viewed by clicking on Event Strip or FD Strip. It is not uncommon for some patients to have their time log filled with numerous clinical events within a very short period of time. For example, when a patient has persistent atrial fibrillation and rapid ventricular response. This can prevent one from viewing more remote events in the chronological log. When this is the case, it is helpful to go back and search by event type so as not to miss any events. This next section will focus on the use of calipers to make measurement of different telemetry events that have been identified either by the graphical trend method or by the clinical event method. Once an event has been identified, it can be focused on by clicking on calipers. The lead being used can be changed to best optimize the waveform visualized. The calipers can be manually dragged to measure a specific interval. Clicking Marching Calipers will march the preset interval throughout the tracing. In this case, measuring the RR interval and then moving the calipers to the PP interval and clicking on Marching Calipers reveals that the RR and PP intervals are equal and both regular. Marching calipers can be helpful for documenting the mechanisms of a bradycardia, such as revealing AV dissociation when a patient has complete heart block. Now that the learner has developed a step-by-step method for interrogating telemetry on a daily basis using both the graphical trend and event alarm methods, in this next section the viewer will develop a step-by-step method for determining the etiology of an arrhythmia when one has been identified. It is imperative that when a possible arrhythmia is identified, both the onset and termination of the arrhythmia are closely inspected, as these regions generally offer clues that are diagnostic of certain arrhythmias. When a possible arrhythmia is encountered by an abrupt change in the heart rate in the graphical trends, the first step is to move the cursor to the general time of the event and then narrow the display interval to reveal the shortest possible setting, which is 15 minutes. In doing so, the cursor can then be precisely placed at the exact moment of the heart rate change where an arrhythmia is likely to have started. Once the cursor is appropriately placed, clicking on FD Strip and scrolling forwards or backwards will reveal the real-time waveform at the time of the initiation of the arrhythmia. Specifically, identifying arrhythmias that are initiated with a premature beat, either atrial or ventricular, can give insight into the mechanism of an arrhythmia. Once the onset of an arrhythmia has been inspected, the next step is to examine and measure the actual arrhythmia. This can be done by moving the cursor to a time in the middle of the arrhythmia, which is usually represented by a plateau in heart rate. Once the cursor is appropriately placed, one can see the rhythm by clicking on FD Strip and scrolling. Once a portion of the arrhythmia is in view, clicking on calipers will allow for determination of the rate and regularity of the arrhythmia. In this case, measuring with calipers reveals a narrow complex tachycardia at a rate of about 120 that appears regular with visible P waves. Finally, moving the cursor to the approximate termination of the arrhythmia and then scrolling through the waveforms again in the FD Strip can allow one to precisely identify the offset of the arrhythmia. It is important to identify if an arrhythmia is terminated by a premature beat. Additionally, the offset of tachyarrhythmias should also be inspected for post-conversion pauses or post-conversion bradyarrhythmias, which are fairly common. The process for moving the cursor and inspecting the onset and termination of an arrhythmia is just as important as inspecting the arrhythmia itself and should be repeated for every suspected arrhythmia. One final method for identifying arrhythmias is to use the FD page. FD page displays roughly 5 minutes of telemetry in a zoomed out fashion and is useful for noting abrupt changes in visual grouping of QRS complexes that is often associated with tachy or bradyarrhythmias. The FD page can be used to identify regions of interest in telemetry that are likely to contain an arrhythmia onset or termination. These arrhythmias can be clicked on, which will enlarge the strip to full size for easier inspection. In this example from the prior patient, clicking on FD Strip reveals a transition from a narrow complex tachycardia at the top of the page to a slower rhythm lower down. By finding the approximate transition between the two and clicking on this area, the waveforms at this time can be analyzed more closely at the bottom of the monitor. Or it can be viewed in a separate screen, again by clicking on the FD Strip or Event Strip. We will now conclude by helping the viewer to identify common clinical arrhythmias as well as to determine when artifact is being misinterpreted as an arrhythmia. The following list, while not exhaustive, represents very common clinical events that are diagnosed through proper use of telemetry. It is key to identify episodes of atrial fibrillation that occur because these are likely to change clinical management of the patient. In this example, one can see 2 episodes of abrupt change in heart rate, suggesting that an arrhythmia is likely taking place. Notice that each episode is associated with a thickened graphical trend line, which, as previously mentioned, is the hallmark of atrial fibrillation. Here is another example of a patient with chronic persistent atrial fibrillation, noting again a thickened heart rate trend line. In this case, viewing the 24-hour graphical trend gives the provider an assessment of the heart rate response and can allow for titration of medications to attain a certain heart rate. This is an example that is suggestive of atrial flutter. Unlike atrial fibrillation, in general, atrial flutter is regular and thus the baseline is not particularly thickened. Also, the rate of atrial flutter is determined by the degree of AV node conduction and is usually 2-to-1 at a rate of 150, but can also occur at 3-to-1 at 100 beats per minute or 4-to-1 at 75 beats per minute. Thus, as the example shown here, the graphical trend can often appear like rungs of a ladder as the heart rate changes between these various multiples. Here is an example of the importance of close inspection of the offset of an arrhythmia. In this case, the narrow complex is terminated with a PVC, which suggests that the mechanism of the arrhythmia may be reentrant. Inspection of the rhythm post-PVC can sometimes reveal flutter waves, which suggests that the preceding arrhythmia may in fact have been 2-to-1 atrial flutter. Here is another example of the importance of close inspection of the offset of an arrhythmia. In this case, the arrhythmia does not terminate with a premature beat. Furthermore, use of the calipers will reveal that the narrow complex tachycardia is at a rate exactly double that of the normal sinus rhythm that follows. Here's an example where scrolling through a Y complex tachycardia reveals one narrow beat. This narrow beat, called a capture beat, proves that the Y complex tachycardia is in fact ventricular in etiology as opposed to supraventricular with aberrancy. Finally, it is very important to be able to distinguish true arrhythmias from artifact caused by external motion of the telemetry leads. Motion artifact is extremely common as patients move about the hospital, and incorrectly diagnosing a patient with a dangerous heart rhythm can lead to unnecessary testing and treatment. In this example, a patient brushing his or her teeth creates a waveform that appears similar to a Y complex tachycardia that could be very concerning. There are several tools to distinguish artifact from a true arrhythmia. Firstly, true arrhythmias are present in all leads simultaneously, and in this example, although the bottom lead reveals a concerning tracing, the other 2 leads show a normal narrow rhythm. Additionally, if one looks closely at the bottom lead, there are some QRS complexes that appear to march out in an unaffected fashion throughout the episode in question. This would not be possible if a true arrhythmia were present. Finally, as is in the case here, the frequency of the artifact can often be at or above 300 beats per minute, which would be highly unusual for either ventricular tachycardia or polymorphic ventricular tachycardia. One can also use the oxygen saturation waveform or arterial or central line waveforms present in ICU patients to help assess whether artifact is present. In this example of a real ventricular tachycardia, notice that the arterial line waveform is flatlined, as is the oxygen saturation waveform, suggesting a true clinical compromise. If the event were artifact, the oxygen and arterial waveforms would not have been affected. This concludes this educational session on the use of inpatient telemetry. The viewer should now have the skills to methodically assess telemetry for the presence of arrhythmias, determine the likely etiology of common clinical arrhythmias, and distinguish a true arrhythmia from telemetry artifact.